Well, good morning, everyone. Thank you again for this opportunity. For the presentation this morning, I'll be discussing surgical neurophysiology for the spine and the appropriate responses thereof. So, surgical neurophysiology, excuse me. There we go. So going back to the basics, if imaging is structure, neurophysiology allows us to complement our understanding through function. And it's really the only way to interrogate the nervous system while the patient is under anesthesia undergoing surgery, allowing us to detect impending injury, warn the surgeon, reduce the incidence and severity of adverse patient outcomes, of course, protect the surgeon hospital in the event of litigation, and is really a defensive technique which allows us to identify functional anatomy and improve surgical precision. The core characteristics of electromonitoring as used in the current era is the focus on multimodal approaches. So multiple redundant modalities. They're the active, intermittent stimulation and recording processes, such as somatosensory evoked potentials, seen on the right, motor evoked potentials, triggered EMG, and then the more passive continuous recordings, such as EMG and EEG on their own. Conceptualizing this at a fundamental level, we know that when we stimulate the sensory process in the nerve going up the dorsal columns, then we are able to record the activity from the brain and the somatosensory cortex. Conversely, with a motor evoked potential, at least a stimulated one, it comes from the motor cortex and then is recorded down within the muscle along with an EMG, allowing for this electrical snapshot at a distant location along this pathway. So in regards to SSEPs, this is a sensory surrogate for the spine through the posterior columns used for the nerve and root as well. Some of the great advantages are the established alarm criteria, the fact that we can use it with paralytics. However, there's some very critical disadvantages in that the average potential can take several minutes to evaluate, and there are known false positives and false negatives within the literature documented. Focusing on the coherent averaging, SSEPs require calculated averages due to the inherent noise within the type of recording that is undergone, and thus can take several minutes to change following an acute insult. Some literature has documented changes lag behind MEP changes by 15 to 16 minutes, up to 33 minutes, at least within this 2004 study. And such, with this critical limitation, it's important to use additional modalities in order to really understand the processes within the surgery. So, for example, EMG, able to use to evaluate the motor aspect of the cord, the lower motor nerve, the root, or the nerves themselves. It's providing instantaneous feedback. It's passive, continuous. However, at this point, there's no clear, definitive guidelines or alarm criteria. And similarly, conversely to SSEPs, you are unable to use it with paralytics, and it's not as comprehensive as a motor evoked potential. A simple free run EMG allows us to identify irritated nerves or injured nerves, which are firing spontaneously versus the normal muscle and generally electrically quiet waveform we can see at the top, compared to the spike discharges, bursts, or the train activity, leading to neurotonic discharge with prolonged bursting. A highlight of the EMG is the triggered EMG, and this is a stimulus time-locked EMG, which allows us to extend its utility. By using a probe, we can seek out unseen neural elements, we can test pedicle screws, and verify the viability of the nerve that is being stimulated. Now, this concept is several decades old. However, one very large study, which was very seminal in putting together a lot of this literature, is the Raynor 2007 correlation between low triggered electrical myographic thresholds and lumbar pedicle screw malposition, an analysis of 4,857 screws. And this, using such a large number of patients, was able to kind of consolidate some of the data which was already being reported and put numbers in terms of milliamperes of what we would be considered an alarm criteria for the probability of a medial breach following the placement of a pedicle screw. The various Numbers seen here within the table, less than 2.8 almost assuredly has a medial breach with a very high specificity, a low sensitivity, less than 4, very high probability, and then if greater than 8 milliamperes, we can see that there's a very high sensitivity and specificity, that there is a 0.31% probability of a medial breach, very low. And so within most ORs, if you're greater than 8, generally the surgeon should be satisfied with the placement of the screw, at least from electrophysiologic perspective, in terms of a medial breach. This is simply a gathering of some of the data which had built up to this larger study starting back in 1994, all the way up to 2007. And of course, in the past decade, several more papers have come out, leading to this recent 2015 review and meta-analysis of the diagnostic test accuracy, which agrees with the threshold of greater than 8 milliamperes to have a relatively competent, to feel relatively confident that the pedicle screw is in the appropriate location, at least when it comes to the medial aspect of its placement. However, this was simply looking at the anatomy of whether there was a physical breach. And so more recent papers, such as seen here in the 2021 Global Spine, triggered EMG as a useful intraoperative adjunct to predict post-operative neurologic deficit following lumbar pedicle screw instrumentation, has moved on to attempting to confirm that these alarms and the detection of these alert criteria are associated with improved patient outcomes, or if they are present, with a decrease in or an increase in post-operative neurologic deficits. And so the main finding from this paper is that these thresholds are highly specific but weakly sensitive for new post-operative neurologic deficits. However, patients with the new post-operative neurodeficits are 10 times more likely to have a lumbar pedicle screw stimulated at a low threshold within the procedure. Moving on to transcranial motor evoked potentials. This is coverage of motor for the spine, the root, the nerve. What's an advantage is that it's comprehensive motor tract coverage. It has the highest sensitivity and specificity of all modalities. However, it does require invasive intermittent stimulation, requiring an actual activation by the surgeon or by the electrophysiologist. The alarm criteria is somewhat subjective and unable to be used with paralytics, with also a very significant effect of anesthesia on the outcomes. Similar to SSEPs, recent data has been focusing on attempting to confirm that these alert criteria are not simply products within the OR, that they lead on to improve patient outcomes once in the postoperative phase. And so we can see within this first article here that the diagnostic accuracy of MEPs for anterior tibialis related root dysfunction is improved by the use of motor evoked potentials and leads to improved outcomes following their use within lumbosacral procedures. And an extension of that, the use of MEPs should really be focused on multiple myotomes to really improve the sensitivity and specificity in order to most accurately detect new postoperative injury in this situation, focusing on dorsiflexion injury. As alluded to earlier, unfortunately, a single universal warning criterion for motor evoked potentials has yet to be completely decided and determined. 3 commonly used techniques are the threshold technique, which essentially results in an alert criteria should the myogenic responses decrease below 65% of baseline values. And then the amplitude technique, essentially checking for the stimulus and ensuring that the amplitude of the response is maintained no matter what the stimulus is placed, as long as it's within appropriate threshold limits. And then of course the all or none technique, which allows for an increase of stimulus to the maximum and a decrease of the amplitude so long as there is a reproducible response following the stimulation. Now, it's impossible to discuss neuromonitoring or electrophysiology without highlighting the effect of anesthesia on its modalities. So the halogenated gases are very well known to disrupt MEPs and SSEPs, amplitude and latency, greatest being nitrous and so on, which is why electrophysiologists strongly prefer the use of IV agents or TIVA. Listed below are several other effects from propofol, dexaminate, opioids, etc. But the emphasis of TIVA will help reduce the effect of anesthetic fade, which can be commonly seen with propofol. Here's simply an example of what could be considered an alarm criteria if taken completely out of context, wherein we can see at the bottom strong responses, especially within the third column, becoming much more noise-like and unable to really discern due to the prolonged nature of the surgery and the slow but constant anesthetic fade. To help supplement this, the use of an EEG can be very powerful. This, of course, begs the question, this is spine surgery, why do we care about an EEG? But this allows for a measurement of the depth of consciousness for anesthesiologists, which does not rely on halogenated gases. Typically, anesthesiologists are very familiar with the use of a minimal alveolar concentration, or MAC, with volatiles. However, once they become familiar with the use of burst suppression on an EEG, which is a hallmark of absence of consciousness or the full use of TIVA, it can provide for more optimal electrophysiology recordings, and therefore greater sensitivity and specificity for the surgeon during its use. Now, highlighting the overall known alarm criteria, with SSEPs, there's a 50-10 criteria, greater than 50% drop in amplitude or greater than 10% shift in latency. With MEPs, less well-defined, the presence or absence, but generally understood to be a greater than 65% drop in amplitude for baseline. And then with an EMG, no particular guideline, however, the change within the amount of high amplitude discharges, be it burst or individual. Now, of course, as alluded to earlier, there are several factors which will affect the alert criteria. There's the initial waveform variability, known technical issues such as the BOVI causing significant artifact, the use of gases, the length of anesthesia producing fade, the pre-existence of neurologic injury, myelopathy, or strength less than 3 out of 5 generally is associated with very poor MEP recordings. The rate of changes and, of course, the timing in which the change occurs, whether this is occurring during the flip, during the placement of the rod, or if there's a sudden change while there's a simple dissection going on without any clear reason for it. As such, there is a very wide differential for changes within electrophysiology. Most commonly, non-physiological or technical. The wires are pulled out, a cable is disconnected, the general noise occurring from the overall recordings, the use of the bed, the drill, C-arm, bear huggers, changes within blood pressure, extreme blood loss with a drop in hematocrit, changes in temperature, pH, the adding of gas during anesthesia. Of course, there's patient positioning issues. However, the one that we fear most of all, of course, is the physiologic surgical change. As such, there is a general algorithm for the change within, or an alert criteria within electrophysiology. So first, there's a time-sensitive recognition, the confirmation that this is in fact a true alert criteria, evaluating the first stage of the differential, whether this is physiologic or non-physiologic, at which point you would re-optimize. If it is physiologic, communicating with anesthesia and understanding why this non-surgical change may have occurred, a change in blood pressure, temperature, the addition of gas, and discussing with anesthesia versus the physiological or surgical change. Thankfully, the least common of these, but it is at this point that a verbalized alarm criteria with the surgeon and anesthesia would be activated. As such, the response, at least with the anesthesiologist, is to decrease stop gases, optimize signal, use ketamine, the addition of boluses, pressors to increase the pressure, ideally to a floor of 80 for MAPS. This is just relating to the perfusion pressure within the brain as well as within the spine to ensure that there are no ischemic changes, and then the addition of blood products for significant blood loss. With the surgeon at this point, if there's no clear change, there's a discussion on the release or adjustment of traction, the controversial application of steroids within the field, a Stagnara wake-up test, abbreviating the surgery, or discussing why this may be a false positive and critically evaluating the field and proceeding based off the index of suspicion. One article which really puts this together in a kind of clear intraoperative checklist for neurophysiologists to utilize is this Neuromodality in Spinal Deformity Surgery, a multimodal approach from Global Spine in 2018, where the neurophysiologist, if they detect an alert criteria, need to gain control of the room, activate a pause, eliminate the extraneous stimuli, very much like a timeout or a brief, discuss it with the appropriate anesthesiologist, the surgeon, and then go through those differentials, optimizing the map, hematocrit, pH, ensuring that there's normothermia, discussing the use of the anesthetic agents, the extent of the neuromuscular blockade, perhaps using a train of 4, ensuring that the electrodes and connections are appropriate, evaluating positioning, and then finally moving on to the surgical options, which include the removal of traction, the removal of distraction or other corrective forces which may have just been placed, the removal of rods, screws, and evaluating for a breach using a pedicle finder or a ball tip probe, evaluating for compression, and then the use of an intraoperative imaging modality, such as a O-arm or C-arm, to see whether a placement of an implant or screw may have been malpositioned. And of course, fortunately, most changes are reversible. And that's why the specificity for the multimodal electrophysiologist can be somewhat low, with one paper reporting 6.3% of patients having some sort of alarm, while only 3.4% having post-op deficits, half. And of course, referring back to previous discussion, the SSEPs are delayed compared to MEPs by a solid 5 to 16 minutes, up to 33 minutes, depending on which paper you look at. As such, adverse events are more closely associated with MEPs rather than SSEPs, with a lower rate of false positives. Now, the discussion of neuromonitoring within Transpsoas procedures could warrant a whole hour in and of itself, but I think it's important to highlight the slight difference in the way that they're used when approaching the psoas and trying to avoid the lumbar plexus. As such, within the past decade, several papers have come out discussing the clinical utility of EMG, MEPs, and SSEPs within lateral surgery in order to best avoid any postoperative deficits. The EMG, low specificity, may not detect nerve compression. However, the use of directional EMG, especially when approaching the psoas, going through the psoas, and before the eventual expansion of the retractor, allows the surgeon to identify the proximity of the lumbar plexus within the psoas. The use of MEPs, able to accurately monitor the peripherals of the lumbar plexus. However, similar limitations as within a posterior approach apply, necessitating the avoidance of inhalational anesthesia and long-acting paralytics. And finally, the SSEPs, the use of the saphenous as a marker for the high lumbosacral plexus, as well as the posterior tibial or perineal nerves for the lower lumbosacral plexus. However, at this point, the use or combined use of EMG, MEPs, and SSEPs in the lateral approach remains without consensus, which brings us to a discussion of the overall guidelines for the use of electrophysiological monitoring for surgery of the spinal column and spinal cord. This is coming from 2017, so 5 years ago, the most recent rendition of these guidelines, which ultimately suggests that for diagnostic purposes, intraoperatively, multimodal intraoperative monitoring is reliable and a valid adjunct for cord integrity. However, when used as a preventative measure, there's still, at least reported, insufficient evidence to conclusively determine that there is an improvement in neurophysiologic outcome following the use of neuromonitoring. As I showed earlier, there are several newer papers demonstrating a good correlation between the use of neuromonitoring and improved outcomes. However, at this time, it has not been conclusively included within the guidelines. And so I look forward to the next rendition where hopefully more of these papers can be included and evaluated so that we may perhaps have a more definitive answer to what we all essentially kind of feel to be true, that the use of this, at least within the appropriate surgical hands with the appropriate neurologist or technician, can lead to an improved surgical outcome for these patients, or at least the avoidance of complications. This finding also holds true for the lateral approaches, with insufficient evidence to confirm that there is a use for it as a therapeutic adjunct to reduce iatrogenic nerve injury or improvement in postoperative neurologic outcome. However, in my experience, seeing that there is a change rapidly leads to a reduction in overall retraction time. And that in and of itself, I feel with enough data will lead towards a hopeful documentation within the literature that there is a very clear and significant benefit to the use of electrophysiology, at least within the lateral approach. And when discussing cost effectiveness, similar sort of problem, insufficient data to confirm that the use of intraoperative monitoring is a cost-effective measure. However, I also expect that this will improve as more data is parsed out. And so I appreciate your time. I'm open to any questions that may arise or go back to any screen to discuss any papers that were discussed. Thank you.
Thank you, Danny. That was excellent. I've got a question for you about the screw testing. How much do you know, or have you seen in the literature about the different metallurgies and that influence on testing parameters? Meaning, the stainless steel versus titanium alloy screws. My sense is that titanium alloy screws don't test the same way, and I'm not sure where most of the literature came from. Whether it was, from the days of stainless steel screw use that was much more prevalent, or whether we're getting, more accurate numbers from recent titanium alloy testing.
I have to say that's an excellent question, and unfortunately, I did not come upon that while putting this together. But it's something that I'm definitely gonna look into, because that is a very interesting idea to see if they do measure at different milliamperes.
So much of the testing that's done, or the use of this and what we've learned from it, I think, has come from pediatric deformity, where testing's done a lot more substantially. And I know for many decades, and still because of cost, they'll use stainless steel fixation more commonly than we do in adults. So just an interesting question that may influence how we perceive things. So, yeah, I look forward to hearing more about that.
I appreciate it.
Yeah, a lot of this paper came out of WashU. There, a lot of them are Larry's papers. So I don't know what his practice patterns were like in the in the late 90s and early 2000s, where most of that data came from. It'd be interesting to look into that. Danny, the other thing to highlight for the fellows is, I think it's really important if you're going to be doing cervical myelopathy or thoracic cases, probably more so than lumbar, in my gestalt, that you have a very fluid working knowledge of that algorithm that you showed, Danny. That paper, I think, is one of the seminal papers that we quote in spine deformity for sure, but I would say in spine in general, that is related to patients that are suffering from spinal cord compression. So you have to have a real good working knowledge of that, because you may have different neurophysiologists covering your cases depending on the community that you're in. You may not be lucky enough, the way we are, to have very consistent, neurophysiologists in our room. And so when you have a constant change, you're still responsible. And so it's important for you to have like a really good working knowledge of this, so that when things do hit the fan, that you're able to calmly and collectively kind of work your way through the different reasons why things can happen. Certainly, the longer the case goes, you'll see all those factors that influence it that Danny talked about, whether it's temperature or blood pressure or sag from, anesthesia. Sometimes anesthesia sees stuff in the back, and then they add an inhalant, don't even tell you, or they double down on propofol and don't tell you, or like all of a sudden, like you see this like sag that happens. So you have to know, the right questions to ask and to be able to lead your team in that way. So thanks, Danny, for highlighting all that. Just wanted to make sure the fellows also had a good understanding of when you get out there, like just have a real good working knowledge of this.
Especially to add to Greg's point, when you're starting too, and frankly, all of us, it's not a bad idea to have that checklist printed up, just like we do for surgical timeouts, so that, when you're stressed out, you're tired in the midst of the case, it's usually typically later on in the case, that you can just go straight to that checklist and make sure you don't forget anything on it. It's a good way to be thorough.
Another thing, Dan, that I thought was interesting was some of the indications, like in degen for neuromonitoring. As you alluded to, it's probably something that's dramatically overused. And like I stopped using it in ALIFs. I still use it for just like cervical radiculopathy. Obviously, I use it for myelopathy, but the utility obviously has not been clearly demonstrated in those contexts. And and just like the radiculopathy context, we even have some partners, or not in Scripps Clinic, but in Scripps Health, that use it for like discs. And, I think that there's really no good evidence to suggest that is additive. So it'll be interesting to see how that evolves over, the next, 10 to 15 years, as the economy of spine continues to pose challenges, if that's reined in at all. You know what I just thought of? I wonder if there's a way to study the use of neuromonitoring for like single level ACDFs without myelopathy in surgery centers versus like physician owned surgery centers versus hospitals, and if that would show a significant difference.
Yeah, I mean, more goes into that too, because a lot of physicians own their monitoring, and monitoring can be a lucrative. It can be lucrative. So not for better or worse, but there can be a conflict even within that. But be interesting to see the application of that technology in those two environments, because it'll probably tell you pretty quick one versus the other, right?
Yeah,
I agree.
I guess we all know the answer.
I think the cervical spine with just like, you're just doing an ACDF for D to D with up down stenosis or whatnot. Same thing for an ALIF. I've been phenomenally underwhelmed with the ability for monitoring to pick up on the L5 root issues. And I've had plenty of patients wake up with L5 dysfunction that were not picked up in surgery. And I don't know if it's like it wasn't present in surgery, but then like 30 minutes afterwards it is. But it's not like I can run MEPs in the PACU. They'd wake up faster, I guess. But it's not a reasonable thing to do. But I don't know. Like I know the data says on the root level it seems to be good, but I would say in my practice that's not held true.
I didn't realize surgeons could own neuromonitoring. I mean, it seems like a pretty clear conflict. But yeah, interesting.
You can own just about anything, Hanny.
Yeah, although the payers are getting into the business of blockade, so that they're when you start going through, and now Medicare probably get into this too, pre-auth, that they will ask those sorts of probing questions, and potentially not cover. And so patients are more and more getting hit with bills afterwards with non-coverage of that kind of service. So you have to be thoughtful about what the patient's going to get afterwards, and they'll they'll let you know about the discontent. So the whole process is changing a little bit, and I think it'll thwart some of that sort of questionable behavior in part.
Yeah, I totally agree. It's changing for sure. That is a very common thing to get. I mean, I've had monitoring denied for deformity surgery, which is like crazy.
Really?
Oh yeah.
I've had it denied for myelopathy too.
Yeah, so you have to go like give them the data and send them articles. It's like, come on, guys. It's actually
Silly.
Well, thanks, guys. It's about that time. Dan, appreciate you presenting. It was awesome. Great stimulus for conversation, and look forward to seeing you guys next week. Thank you.